Is that any better?
We can still hear the echo.
So
Mohit,
on your other device, Mohit.
I am going on two separate links, but I have switched off the. Give me 1 second. Let me log out and log back in.
No, so Mohit, you don't necessarily have to log out. You just need to take off the audio from from one of the devices.
Take off what?
The audio. So you know where your microphone is?
Yeah.
If you click on the arrow, the drop down arrow.
Yeah.
Yeah.
And you say leave computer audio.
Done. Any better?
Perfect.
Yeah. Perfect.
Oh dear God, this is just driving me insane. Right. Okay. Which device are you seeing me? Now you're seeing me on the one on the side, so I must move that to the front, isn't it? And switch off my thing from here. Can we just relook at device? Am I the right height, the device, or do I need to change that around? Sarah?
I can't see you on the main device. So I'm asking you to start.
I have switched off my main device on purpose because that's the one that's giving me trouble. That I'm using now the 3G rather than using the hotel Wi-Fi. That's why I moved out.
Fantastic. Yeah, it's much better.
So can you put me on the second device?
So which is the Yahoo Mail. So you want?
Yes, please. And rename me there as Dr. Mohit Venkatram and take me off from here.
Oh, yes. Fantastic. I've just done that.
And
if you turn on the camera on the one that she just renamed you, Mohit.
So how do I turn? My camera is already on this one.
No, the other device.
I have turned on the camera on the other device, Ruth. It is on. Can't you people see me? I can see myself.
I can see you, Mohit. I can see you.
So Elaine can see me. Can the others
we can see you?
You can, but you've got the wrong name. So Sarah, in this one, can you name this Dr. Mohit Venkatram and take it off from the other one?
Yeah.
And the moment you do it, I'll switch on the webinar. Let's go.
Oh, perfect. We are on.
Super. So shall we give a start to this then? Do you want to invite people in?
Yep. People are in.
Colleagues, good evening. I'm Mohit Venkatram, and welcome to another fabulous event on the strategic series on the future of primary care. You'll recall in the previous events, I have spoken about how at East London Foundation Trust, we created the Directorate of Primary Care with a view to recognizing that the leadership, the strategy for the future of the NHS, ensuring our people got the best outcome, ensuring inequalities, which we have all experienced in the last few years, are managed much better by the NHS, requires the leadership of primary care. Often, we have been looking at working with our partners in primary care, recognizing that jointly we are a much stronger entity in delivering the right outcomes. I'm today in Liverpool at the large NHS Confed conference, and the Secretary of State himself mentioned the leadership role primary care plays in the delivery of care in the NHS. Despite this, over the last few months, we have been hearing from the media a lot about how getting GP appointments has been difficult, how the ability to provide care in primary care seems to be outdated, how primary care is not able to meet the needs of our community. So I was looking at the healthcare data for the month of March. In March alone, primary care provided 25.3 million appointments. The fuller report talks about providing urgent care and providing planned care through two different streams. In primary care, in the month of March, 45.2% of appointments, which is half literally the number of appointments, were urgent appointments offered on the same day for patients. Almost 50% of people of the 25.3 million people seen in the month of March was seen by GPs alone. It does show the enormity of work that happens in primary care. Phenomenally important for us in our series to continue to focus on how we can do together creation of a new NHS along with our partners. Today's discussion is very special. It's special for two reasons. It's special because we have completed our first anniversary of the Future of Primary Care strategic series. So our amazing team in the Trust have ensured today's session is streamed on all our social media platforms. Now, for someone of my age, I have no clue what that means. But in my days, we used to call it being broadcast. I believe my kids have told me I'm not supposed to use that word, so I'm going to use the word streaming. And it's phenomenal to know, actually, you can watch this episode today on any of the platforms like Facebook, Twitter, you name it, and you've got it. We also have got a very special series today because we are talking about a subject that's very close to my heart, a subject which has touched many of us in the last year, the subject of inequalities, the subject that has worried us in the pandemic in terms of how many people have been affected in a way that has made us reconsider if healthcare provision is being done in a way that is fair, that's equitable, that's transparent. There are many things in primary care that stand out starkly in the area of equalities. Funding in primary care is unequal. The Cahill formula doesn't always give funding to the right places effectively, making it really hard for good primary care to be delivered. An assessment of the CQC outcome report published by the Royal College demonstrated that GP practices run by ethnic minority GPs were more likely to have a poorer CQC outcome compared to other GP practices. GP staff feedback survey shows ethnic minority staff in GP practices are likely to have a worse outcome. Areas served by GPs where the ethnic minority are in high proportion would have fewer GPs per 100,000 residents. These are difficult figures for us to accept in 21st century, 22nd century, 23rd century. These were difficult for us to accept in the 19th century. So how can we today sit back and accept that these figures are acceptable? So what is happening? What is the policy direction to improve these outcomes so that together we can provide the best care to all residents we can provide equitable care to all residents. We can ensure staff within practices have equitable outcomes, whether they are BME staff or other staff. Our speaker today is the amazing Elaine Goodwin. She is the national lead for inequalities in primary care, a very good colleague and friend who's been telling me about the amazing work that's been happening. Without further ado, I will hand over to Elaine, but just before I do, a quick reminder, please do use the Q&A session of the chat box so that you can post your questions as Elaine shares her thoughts, and we'll then open it up for a conversation. Elaine, thank you so much for coming. Over to you.
Brilliant. Thank you so much for that introduction. And also thank you for inviting me today on your year's anniversary. So that's a huge privilege. I'm sure you've done lots of fabulous work so far. So hello, everybody. As Mohit has just said, my name's Elaine Goodwin. Actually, you gave me the very honourable title of Health Inequalities Lead for Primary Care. My role is actually Inclusion Health Lead nationally, and that's for NHS England. And I work between the Chief Nursing Officers teams and the Health Inequalities team. So a big part of my work is around health inequalities and that agenda within primary care, but my role is particular that sort of deep lens around inclusion health. So thank you again for inviting me. So next slide, please. So this next slide is a slide that I put together soon after I started in post. I've been in post since October 2020, where I was appointed by Ruth May, the Chief Nursing Officer, to look at inclusion health, to look at what basically the priorities were. And I was asked to do a quick desktop review. And this was a kind of articulation that I did of that at the time. And I've left it on here because for me, it reflects what we all know, I'm sure, but what the system mustn't forget as well about how the pandemic really shone a light on those living in vulnerable conditions and how it's substantially magnified inequalities gaps. We had Marmot's COVID-19 review that concluded inequalities in social and economic conditions before the pandemic contributed to the UK's death toll, which I'm sure you'll all have heard of. There was also a range of reports around the time I started, before and just after, evidencing that some of the population groups within our societies have significantly lower life expectancies than the general population. And I'll talk a little bit about that more in a minute. But examples on here are the Dying Homeless Project that identified that a third of people who are homeless die from intolerable treatable conditions such as TB or gastric ulcers. There was a Pathways report on frailty, which was really shocking to me, even though I've worked in this space for a long time, but identified that men and women who are homeless at or around the time of death live 31 years and 38 years fewer than the average respectively. So, and also within this, there was a number of reports around GP access to GP primary care and registration and kind of barriers around that as well. Next slide, please. So I would like to focus on inclusion health for this conversation, but further on, I'll talk a bit wider around the health inequality drivers. So what do we mean by inclusion health? It's a lens that sits within the health inequalities agenda on the people most likely to be systematically excluded from society, but also often from within our systems. And those people typically experience multiple overlapping risk factors for poor health, and they often experience stigma and discrimination. A key aspect of the inclusion health agenda is that it's often people who are not consistently accounted for in electronic records as well. So I've listed on here who those people can include, and obviously not all people who are homeless or have drug and alcohol dependence or are vulnerable migrants, for example, would fit this criteria. But we understand that the populations identified here are much more likely than the average population to have significant issues, and they're much more likely to experience structural barriers that frequently lead to poor access experience and poor health outcomes. And the three key priorities for the Health Inequalities team nationally, and that national agenda is about how we improve access, experience and outcomes. So around inclusion health and the long-term plan, this slide here just puts into context a little bit more of what I've said already. When we look at deciles of multiple deprivation and standard mortality ratios, when you layer those with people who are homeless and severely excluded, you can see there's a huge disparity around those ratios. Also, when we look at prevalence of long-term conditions, on the right, the blue bars are around, again, deciles of multiple deprivation. But then again, when we layer around the sort of homeless element, we can see a huge kind of impact there on outcomes for people. Interestingly, you'll see diabetes is less of a disparity, but when the report that looked into this identified that actually probably because most people die before an age where you would expect type 2 diabetes to be prevalent, sadly so. So next slide, please. So one of the challenges for all of us is how we ensure how the whole system responds to this agenda and the broader health inequalities agenda as we've touched on already. And I won't go through all of this, but these are some of the areas that I've focused on in the last 18 months to try and support that from a national perspective. And so as the visuals on the right kind of visualize, I suppose, this kind of ambition and piece really around what often is the reality for our society and for some of our systems, that, you know, our ambition is to move to quality. There's lots of examples of that, but particularly equity, where we've got systems and we've got responses in place that reach people. So as the fourth section there, I suppose, is an ambition for us all. I'm sure that we get to a point in society where actually we don't need these kind of extra responses to meet needs. So next slide, please. So I've added on here just some of the key national health drivers, particularly in relation to health inequalities, and then looking at inclusion health. So obviously we've got the new Health and Care Act, that within that act it gives clearer responsibilities, legal responsibilities for ICSs and systems and the NHS around responsibilities in relation to how we improve the agenda around health inequalities. Also within that act, currently the Department of Health are looking at a duty to collaborate for inclusion health, which we're aiming and hoping will be kind of guidance will come out around that in the summer, sort of late summer. There are other elements there around some of the key national drivers, which I'm sure you'll be aware of most of them. The recent NICE guidance that's come out around homelessness is really supportive to systems as well, and gives good examples of how a system we need to work together in a more integrated way and how we can go about doing that. There's a range of pieces of work going on around vulnerable migrants as well. There's a national steering group that's been set up off the back of a report that I wrote last year. There's big pieces of work going on around the asylum system and other vulnerable migrants, such as the Afghan response that we've had recently and Ukraine currently. Then we've had various inquiries as well. We've had the Kerslake Commission that has given a range of recommendations, particularly around access to healthcare for vulnerable groups and in that inclusion health space. And there's a health disparities inquiry as well that brought about a range of recommendations. So next slide, please. So as part of my work within this portfolio looking at inclusion health, one of the things I've been looking at is the priorities for the next year nationally. And as part of doing that, I did a range of engagement sessions with people of lived experience, and that was at a national level and various kind of regional levels as well, particularly within the London area with Groundswell and others. I also used a range of the feedback I'd had over the 18 months I've been in post. So obviously I've worked a lot with lived experience groups as well. So these were the key themes. And just to say, the number one theme is the key theme I want to sort of focus on really, and because this was quite overwhelming in the feedback, and I've been in a meeting earlier today actually with Groundswell that are looking at another key project, where the overwhelming kind of feeling was that people feel they want to be treated as people and often don't feel that that's the case. So people are often feeling like they're treated as labels. So so some of it's about how we get back to some of those basics about you know, what matters to people, trauma-informed care. I know they're all quite sort of buzzwords, and you know, but how we make those things, really bring those things to life with people, and how we kind of really focus on what matters to people. And then there were other areas on there, and you can see there were a key aspect that was around reducing barriers to accessing GPs, and that was kind of around sort of front door access to front door services generally. So you know, your A&Es, your primary care, and other kind of services. So next slide, please. There were other broad themes from the work and the reach that I did from all stakeholders, and by all stakeholders I mean at a kind of cross-government level, but also I reached out to other sort of third sector providers and key kind of inclusion health leads across the region, and ICS leads as well. And again, around here there were kind of themes that married up with the lived experience feedback, so relate to sort of trauma-informed care and compassionate care, improved access. There was also a range of feedback around the pandemic and elective recovery and equity for waiting lists also, which are key. There's recent research and report that's about to be published by Friends, Family and Travellers that was commissioned through the Health and Wellbeing Alliance that I co-chair around nomadic communities, and there's some good recommendations that are coming out through that report about how we can ensure that if somebody's nomadic, that they have better access to services, particularly around primary care access. Also, the need to collaborate across systems. Obviously, we've got huge opportunities with the ICSs coming into place on 1st of July. Not that they can wave a magic wand, but actually, you know, they should provide some of the mechanisms to really look at that kind of need to join up to meet this agenda. And also around just looking at kind of how we understand the need around this population. So these populations, so for example, we now have the national data set for health inequalities, but actually what do we want to achieve for inclusion health? So those more excluded populations within the health inequalities agenda that often don't show up in data. And also how a big drive around how we make inclusion health everybody's business. And that's at a kind of individual and system level, whether that be nationally or your system level as well. Next slide, please. So we know that the health inequalities in itself is a really broad agenda, and you know, meeting that agenda is massive. So nationally, we're currently determining what our focused support systems will be, and how we can support you as kind of systems as well. What we've done within the inclusion health agenda is look at the kind of priorities of how we may go about doing that. So these are the proposed 4 priorities we've got nationally for next year. The first one being developing an interactive tool to support ICSs and systems like yourselves around meeting the health needs of inclusion health groups. And that is built on what already exists, which is a really good PCN tool around sort of self-assessment around meeting the needs of inclusion health groups. And if you've not seen that tool, there's a link to it on these slides. I'd really encourage you to have a look at that. The feedback is that it's a really helpful tool, improvement tool. And we want to build on evidence and tools that exist already. We know there's lots of good work out there. The idea and the ambition of the interactive tool will be that it will point to key guidance, it will point to exemplars, and also we're looking at some funding, pots of money to develop kind of pilots, or not pilots, but to develop sort of scale and spread approaches. We're also looking at developing a minimum data set for inclusion health of some of the feedback we've had, what that should look like. So the first part of that will be around a scoping piece of what that should look like. What is it our ambition is to get to? And then there's a couple of areas of work that my roles are kind of nursing and policy roles. So the next two kind of sit more in that kind of broader nursing lens. So continue to work around meeting the vulnerable migrants agenda. And there's a number of things going on in that space. And then around children and young people in temporary accommodation, where we know there's big impacts from the pandemic, and also obviously as well concerns for the future around the kind of the situation from a country perspective that we're in around kind of the current sort of austerity, et cetera. So yeah, so they're the kind of 4 areas that we're looking at nationally. Next slide, please. So just looking at the core 20+5, and I'm making the assumption that most of you will be aware of it, if not understand some of the detail of it. It is a key vehicle driver for change. It is something that's cited within the Health and Social Care Bill. I have heard some pushback, criticism of it. I get that. You know, actually, what difference is it really going to make? So there's one thing I would be saying to you as a group of, you know, fabulous leaders in this space. It's a key lever and driver, and the plus element within that is around ICS determined population groups that experience poorer than average health access and experience. So the plus element within the core 20+5 is about how the ICSs look at those population groups that don't necessarily come through when we look at deprivation data, or where we think there's specifically a piece of work to improve on kind of outcomes. And one of the things we're looking at around the plus offer, around all of the core 20+5 and health and qualities, but particularly around the plus offer, is around how we, I suppose, hold the mirror up, but also how we support systems to account for what they are and what they aren't doing, recognising that we can't do everything at once. So yeah, we absolutely recognise it's a huge juggle in a system that's already massively stretched. So next slide, please. So these are just a kind of summary of some of the enabling and supporting system improvements, things in place. Touched on some of these already. Obviously, there's NHS standard contract planning guidance, and there's the PCN's health and quality DESs. I know you touched on, at the beginning around some of the problems with the Cahill formula, again, looking at how we can kind of unblock some of those aspects around commissioning and support ICSs in the future to kind of think more broadly around that. And then next slide, please. So this is something that I've taken from a gov.uk page, which is actually the link to it's on the next page, but just really about, I suppose, how we have that conversation, maybe we can touch on it now, around how we enable and support systems and how we drive that kind of call to action at either a frontline service or a strategic level. And these are just some of the kind of key prompts around that. Certainly, obviously, like local health watches are key, what's in joint needs, strategic needs assessments in relation to sort of inclusion health, wider health inequalities, and how I suppose there can be, you know, real sort of highlight on what's important to really focus on over the next year. And I think it's 5 years that the ICSs are going to have in place planning processes, particularly thinking of the strong feedback within the system around that compassion piece and that treating people as individuals, but also around that access, and particularly around access to primary care. And next slide, please. So this is just some further information that I thought might be helpful. And within that, there's certainly one thing I would point to, if you've not seen it already, is the Safe Surgeries Toolkit. That's quite a good toolkit to support practices around, I suppose that that how we kind of respond and ensure that our offer to people isn't about one size fits all. And then there's just touching on some other pieces there as well. And I think that was it for the presentation. I think that's it. And just on the last slide, there is, within NHS England, we do have some networks that you can join. And I've just put the links there into the space for that, and also our contact details.
Brilliant. Absolutely brilliant, Elaine. Ruth, would you like to put the slides down, please? And put us back for Elaine and me to be focused on. Thank you. This is really helpful. Elaine, what a phenomenal presentation. I mean, packed with information, absolutely packed. And it makes it really hard not to recognize how much of work's already being done in this area. What's really worrying, though, is some statistics that you spoke about. The 31 years shorter lifespan for someone who's vulnerable is shocking. It's absolutely shocking. I mean, I work in East London, and people always talk about the health inequalities from the West to the East, but it's not 31 years. And it does make you wonder, in today's day and age, how can it be acceptable for us to be in a place where we don't have the same level of care, the same level of support, the same level of access that everyone deserves equitably? And it differs from a leafy green suburb to people who are actually more deserving, is probably not just the term, but who genuinely need to be cared for more, which is what the NHS was set up for.
Yeah.
So I think there are some really interesting questions that are being posted. Clearly, you have got our fabulous audience today completely riveted, because there are so many things being posted. And I'll probably start with the very first question, which seems the right one to start with in this context. This is a cause that we all believe in, because this is not a cause around inequalities. This is about social justice. This is about all of us believing that we are all equal individuals who need to be treated fairly, equitably, and cared for equitably. So many of our colleagues clearly want to be part of this journey, want to partake in it, but no one really knows where to start. And if there was a GP asking you this question, or someone from a practice asking you this question, what would be your advice to them as to where should be a starting point?
Yeah, I think probably elements I've touched on already, but I suppose within the health inequalities team name changed to healthcare inequalities team, and the focus of the programme really is around, so from a healthcare and an NHS provision perspective, what is it that's within our gift to kind of improve on? And so I think there's two elements to this, because there's a social justice piece. Absolutely, I'm a massive advocate that I suppose that's the broader agenda for the systems, isn't it? It's not for the NHS to sort on their own. The multi-determinants that impact on health, we know, are much broader than what the NHS offers. So I suppose for me, the first thing around that is there's a kind of broader aspect that actually, from an ICS perspective, you would really hope there could be greater collective coming together to kind of address some of these factors on a kind of, well, at an ICS level, but also at a place-based level. So I suppose for me, it's about opportunities to collaborate in that space. I suppose the immediate for me would be around, I suppose, what's within the gift from a primary care level. And so some of the things I've touched on already, the PCN tool for me, it's a really good tool just to kind of have a look at, assess yourselves against. It points to kind of some potential recommendations. So I'd really recommend that. I think, I suppose it's just taking a stock take as to where you're at, and I suppose what your ambitions are about how you may want to improve things. And some of that could be small changes, it could be big. And one of the things within the health inequalities team as well is around how we really focus on things and give them traction, because the agenda for health inequality is so massive that we could spend all our time talking about it and not actually making an impact. So for me, I would really encourage that holding up of the mirror, and some of the resources I've pointed to might help you to do that. But also the Inclusion Health page on gov.uk that talks about some of the examples on a personal level, that to me is a really good reflective piece as well. I've used that before with areas to kind of think through and reflect on what are some of the things that, again, within our gift and that are realistic in a world that's hugely pressured anyway. I mean, the figures you just gave around appointments in primary care, that's huge, isn't it? So it's, I suppose for me, it would be about taking a stock take and thinking about actually, what is it? What is it? What does that tell you? And encourage the lived experience voice within that as well, through your third sector, making some of those connections at a local level. Because we might think we know what people want, need, and are experiencing, but sometimes actually it can be something completely different. We can't always make those assumptions, can we? I suppose we have shared the national findings because they're national in the sense that that's what we heard across the country. I'd really encourage you maybe reflect on some of that as well. Yeah.
And I think it is you're right. I mean, this has to be owned locally, and the new units of primary care, the primary care networks, have to collectively come together to identify the inequalities in their areas, so how inclusion health can be applicable and how each of them can take charge of specific vulnerable groups of people through the population health lens, so that there is a focused effort on making a difference. And I think there was something you said slightly earlier, which did catch me when you said, this is such a big agenda, we can spend hours and hours talking about it. What's important is to pick up a small initiative and make a difference on that. And I think you're absolutely right, because until we make those small differences, the collective smalls we make across the number of primary care networks that exist in the country would be such a large impact, because across the collective, it becomes much larger than the small one. I think there is something else also, Elaine, that's coming out, isn't it? The post-pandemic world is becoming more and more digitized.
Yeah.
It's becoming more digital, and it's becoming, and people often speak about digital inequalities in older people. And I may not agree with that completely, because actually, I'd find it hard not to consider myself getting to be quite an old person. And my mother is much older and she's alive, and actually she's fairly digitally competent. So I think people are right when they say there is digital inequalities, but it's not just old age, it's their adaptability. But there is no doubt people who are vulnerable, people who are homeless, people from many of the communities you were talking about are even more vulnerable and have even less access to digitalization and the ability to access them. What would be an approach, you think, in the newer world, in the newer NHS and the newer healthcare system, that allows us to ensure we don't lose them and completely forget that actually the divide for health inequalities would be much worse with the complete digitization or direction of travel?
Yeah, and this, I suppose, the direction of what we're looking at nationally is around so within the digital agenda, what we're looking at is actually similar principles to like the inclusion health agenda as a whole. It's recognizing that not one size fits all. So it might be that actually, there are groups, parts of the population which are much more likely to struggle with, access through digitalization, for example. So when we're looking at access, we need to look at it as a broad piece. It's not just about a standard way of one way of accessing people. We often talk about people being hard to reach, and some of the language we're trying to change is actually, it's not about people being hard to reach, it's about we design systems that are difficult, that don't reach people. So I think those similar principles we are looking at from a national perspective in a sense of, yes, the digital world is great, but actually it won't reach everyone, it won't suit everyone. Although maybe it may also be about mechanisms of how we support people to engage with that world, but also we know the reality is for some people they will need a different offer. And through the scoping work and what I do kind of generally anyway, you know, I'm hearing that, and I'm sure you'll all be hearing it of sorts through feedback that, you know, for some people where the only mechanism to get into primary care is through a kind of online referral, or that can be really, really difficult, almost impossible. So it's thinking broadly at actually how you reach your population and understanding who your population are. And because historically we design things to fit the kind of middle ground, haven't we, generally speaking, if we're honest, but actually we need to be thinking of our design broader than that. So I don't know if I've actually answered your question, but from a national perspective, we're looking at the digital piece being part of the future, but not all of the future. And that's, for me, how I'd encourage from a primary care perspective across your area that you think about it as well.
And I think you're absolutely right. It is about considering pre-digitization, how we make that difference, so that the systems and processes don't forget the various people that we are set up to serve, because often that gets missed in modernization. I think there's something else that also popped in while you were presenting, and you were talking about access to secondary care from primary care for people who are vulnerable in inclusion health. And the data I was looking at from secondary care, and you'll see from my the kind of life I lead, I love reading data, and I love to understand data, to understand what's actually happening. The data actually shows that in the people who are waiting on the wait list for various services in secondary care, vulnerable people, people from ethnic minority backgrounds are more likely to be hanging longer on wait lists than others. And that adds another dimension of divide for people who are vulnerable and actually need the additional support. Lots of trusts, lots of secondary care trusts have been working on this to try and understand that data and make a difference. But there aren't many others who haven't done that job and haven't spoken about it. Do you have any view, Elaine, of how we can create a system where people who are struggling to focus on the right questions are supported, so that their efforts are garnered towards ensuring inclusion, equality, fairness is the way NHS is delivered?
Again, I think it's that principle of not one size fits all. So I'm on secondment from Leeds Community Healthcare, have been for the last 19 months. I was responsible for like 25 community services in that. I had one of the three sort of portfolios in the trust. And we had podiatry, MSK, dental, a range of services where we had really, really long unfortunate waiting times. Pandemics obviously added to that. What I would reflect on around some of those kind of aspects was that we often manage the waits and the waiting list as one size fits all. When I reflect back now, actually, how much did we really understand so from a waiting list perspective, do we really understand the kind of the population groups within the waiting list? Do we understand some of the barriers that some people, I suppose it's how we prioritise as well, isn't it, moving forward around recovery. There's a range of kind of ways in which we could and should be doing it, but actually makes it really complex. So, for example, if we're giving priority to, we were talking about this the other day, actually, around how we might, where do we start within waiting lists? And there's, yes, it's just kind of how we look at that, but look at that through the lens of really understanding the populations within it. So we knew, for example, when I looked at the dental waits in Leeds, I realised down the line, we had a high instance of DNA from a non-English speaking community, or people who didn't speak English, didn't read English. But funnily enough, all our letters that were going out were in English. So I think it's kind of looking at things through that kind of cross-section lens and not making assumptions. The Friends, Family and Travellers report, I think I made reference to, I'm not sure if I did, because I referred to it earlier in another webinar, but that's a report that's coming out that's been done looking at gypsy travellers, but it's actually about nomadic communities as well. Now, for nomadic communities, so if you're a gypsy traveller or you're somebody in the asylum system who gets moved around regularly, or you're somebody who's homeless surfing, the likelihood is you never get to the top of the waiting list, even if you're lucky to get on it. And then if you get on it, the likelihood is you're more likely to DNA, you're more likely not to reach the top of it. So I suppose my answer is it's complex, but I suppose it's looking at kind of what you can be doing with your waiting lists without looking at as if one size fits all and making assumptions around some of the kind of multifaceted aspects of how we recover from that.
And I think many of colleagues who work in other sectors like the faith sector, the voluntary sector, do a phenomenal piece of work. And Elaine, I know you spoke slightly earlier about Groundswell, and I know them very well because they work with our practices. We've commissioned them to do work with them, and they do an amazing piece of work and make such a difference to the outcome. How do you think can we work with the wider voluntary sector partners who do an amazing job? They absolutely are phenomenal what they do. But unfortunately, often the work they do is not aligned with the work we do in the primary care and the work we do in secondary care, so that together we do this, focus our efforts towards the same outcomes, and often that's not synchronized. How do you think we could create that single system of focus that gives all of us the right answer?
Again, the magic wand of the ICSs. I think, so the ICSs are going to have a responsibility around their kind of partnership boards, aren't they? Where that's where at that kind of strategic level, the partnership plans, I can't remember the exact name of them, but that there'll be an expectation that there's a kind of partnership planning element from an ICS perspective. So I suppose it's how that then feeds in at a place-based level with the fuller report talks about neighbourhood teams and other aspects. So I suppose it's then how you manoeuvre and come together as a PCN level and really bring to life that cross-sector working, which I'm sure you will have examples of. I suppose it's kind of how you build on maybe what's working already. Again, I suppose, and maybe this hasn't reflected on what I've said so far, so apologies if so. I'm sure within the areas that all of you cover, there'll be lots of good examples of good practice. What we're trying to encourage from a national perspective is how we start really building on those rather than keep looking for the problems in the system. We kind of understand a lot of what the problems are, so let's actually focus on what's within our gift to do. And I suppose at working across in that multi-partnership way, I'm sure there'll be examples already that you can maybe identify and build on and share and learn from. Because I've worked a lot frontline in services with the third sector, in asylum services. I've worked with homeless, prisons, absolutely passionate about the benefits of doing that. I suppose it's how from a primary care perspective in such a stretched system, you have the time, I suppose, to do that proactive kind of lens and look at the system, which I suppose is where presumably you're health inequalities leads come in to support you with, and other kind of mechanisms within that kind of neighbourhood team and wider level.
And Elaine, I mean, clearly there's a lot of focus on a lot of aspiration, probably less focus, aspirations about the ICSs giving focus to this area, thinking around inequalities. And inequalities is supposed to be one of the key tasks the ICSs have been tasked to deliver. And we all have a lot of faith, so we have to wait and see. I think they become statutory bodies as of this month, so we will see where it leads us on to. But clearly, the people who will make a difference, the people who have to get together to understand the social justice element of what we are trying to address, are our clinicians, are our frontline staff, are people who are actually have had a rather difficult time in the pandemic. On top of it, evidence is now showing that people from vulnerable backgrounds, ethnic minority backgrounds, who are working in the NHS in primary care are likely to find it harder, whether it be amount of resources that are available for them to deliver, whether it be the number of people available in populations which are very vulnerable, whether it be the experience they have of serving such populations. Clearly, there is no magic wand to answer this. But if there was a framework that you thought would be helpful from the multitude of resources you've spoken of, do you want to share those out so that people who are listening today can start thinking around, those are the kind of resources I could tap into?
I suppose from the people perspective, from the perspective of the workforce, there is the people plan. There's within that frameworks around how we support the workforce moving forward. I'm assuming within your local areas, there's kind of a localized version of that. I don't know. And within that, there are national offers around health and wellbeing that I can share with you if that's helpful. And I suppose it's absolutely about how we prioritize the well-being of our most valuable resource, which is our staff, isn't it? And it's about our cultures, about how we value and how we really kind of, I suppose, recognize the experiences that we've all been through, but particularly within kind of healthcare and primary care, as we're talking about here, but around, I suppose, giving hope and support for the future as well, around kind of building some of that. Recognizing the trauma that some people have been through, lots of people have been through. And I suppose one of the things we were talking, I was on a forum not so long ago around access to supervision for staff and how feeling that that's really inconsistent across systems. And I'm sure you'll recognise this. And one of the really what we came out from the the discussion was the real importance and value that we should be giving to support for staff and support to access supervision and that opportunity to kind of support wellbeing, really. So I suppose, again, a bit like the inclusion health sort of baseline, I suppose it's understanding that baseline for your practice, for your areas, and maybe picking 1 or 2 or 20 things if you're really ambitious to look at improving on, or recognizing what you're doing really well as well, and celebrating that, sharing it. But maybe picking 1 or 2 things that would make a difference in that space. Looking at some of the national supporting systems like the people plan, like some of the healthcare, the offers that are there that can be accessed by anybody in the NHS.
And I think, Elaine, you're absolutely right, isn't it? That there is no magic wand to try and address this, but it will be a lot of small efforts by a multitude of people that will collectively create the one large effort that we all have to do to make a difference. And inclusion health is such a wide area. It is wide in so many ways, because it is not just about the residents who are being served. It's also about the staff who are delivering this care. It's also about the systems of care that are being delivered. It is about the partners who are part of this system. And before long, we realize it requires us to collectively get together and have a determined effort to abolish something we all think shouldn't be there, which is about social justice. At the end of the day, this is about ensuring we all receive the same care, the same support, the same NHS that we dreamt for, which the NHS stands for. And I think we are the best because we are the NHS. And if we are, then we have to make that difference. And we are not the NHS only. We are NHS as wider providers as well, because many of our third sector colleagues, faith sector colleagues who work alongside us to make a difference together deliver those results. So we would really struggle. And I think we are coming close to the end of it. And I think there's a lot that's happening in our chat box. People making comments about systems and processes, and clearly a lot of aspirations hinge on the ICS delivery. Probably a year from now will be the right time for us to sit back and reflect how far the ICS's plan were able to help us move the agenda of inclusion health, move the agenda of inclusivity in a way that we have together made a difference. Today, Elaine, firstly, thank you for your time. It has been absolutely phenomenal, because it's been packed with information, packed with so much of knowledge that you've brought to the table. But more importantly, the energy you bring into the room really fills it up. The digital room felt alive today with the amount of, with the passion you brought forward in this agenda. Now, clearly, some of the data that you shared was shocking. I mean, the 31 years just doesn't seem to go out of my head. How can we have people with a lifespan 31 years shorter than the rest of us and accept it in today's world to be the right way of going ahead? We really have to do something, which means all of us today listening to this, and those who will listen as part of the webinars that are recorded and put out for others, need to consider how within each of our networks, within each of our zones of influence, we are able to collectively make little differences that start impacting on the core 20+5 that Elaine has been talking about today. It's also very reassuring to note that there is policy work happening in the background. There is focus being given to these vulnerable groups, because unless we do something, unless we look at reimagining a new system of delivering an outcome, we would not be able to do this. Clearly, the work you're doing, Elaine, is vital. It is absolutely vital. And I can't think of a more apt person heading something like this, because the passion you bring in is phenomenal to make that difference. And why this is important, the difference, because NHS is not about care. As a clinician, I have always found, as a resident, I have always found that the NHS is about the mental trust bond that is formed between the resident and the organization. That trust which says, when I need help, I will get help. And inclusion health, supporting our vulnerable residents, is key to this. So developing that trust is the right thing to do. And you, Elaine, really do symbolize the fight in ensuring we not only get the trust back, but also make a difference to the inequalities that exist. Of course, today's conversation, unlike many others, was not for us to take away, but was for all of us to join forces with Elaine to really ask the question, what can we do to be part of this? And Elaine, that's something I will leave for you to consider. How can you mobilize us to support you in doing the right thing, so that together, next year, when we review the outcomes from the work we are doing, we are able to sit back, pleased with ourselves that we are leaving behind a world better than what we receive, and making that difference in the long term for our residents. It's an absolute joy to have heard what you had to share today, Elaine. Thank you for your time. And may I just remind everyone, do please remember that in line with what we did last year, July, we will not be having a session, but in August, we will be back on the 17th of August at 7 p.m. And unlike most other times, I'll keep this suspenseful so that when our comms team distributes our speaker, you will know at that point. Until then, thank you everyone for your time. It's been an absolute pleasure and joy, and have a great evening. Please do feedback, use the QR code and feedback to us on how you found the session. And we will then collate your feedback so that we're able to continuously improve these and make these our sessions of joint strategic learning. Have a great evening, and thank you, Elaine, again for your time.
Thank you for inviting me. Thanks a lot.
Bye, everyone.